All right, this lecture is going to be about clinical reasoning and not memorizing a list of drugs as they relate to cognitive disorders across the lifespan. And when we say cognitive disorders, I'm not just talking about the dementias and the neurocognitive decline, but also the cognitive impairment that may accompany situations like, say, depression, anxiety, cognitive disorders related to attention deficit hyperactivity disorder. So we're going to think about neurobiology, not just reflexive prescribing. And I want to clear some things up front. There is no medication that cures cognitive decline. What we're doing when we prescribe is we're going to be targeting specific neurochemical vulnerability symptom clusters and risk states, often under varying conditions of uncertainty. And this is going to be about prescribing in the gray zone. So we'll deal with older adults who are medically complex patients, families asking for something to help memory, and systems that often expect more pharmacologic certainty than the evidence actually supports. And as we move through the material, you'll notice that some concepts will feel familiar, and that's intentional, but the goal here is not novelty. It's going to be for you to recognize patterns, to be safe, and to exercise the necessary restraint. Now, this first section is going to be about laying the neurobiological groundwork. So before we talk about a specific diagnosis or a medication, we need a shared mental model of what cognitive dysfunction actually reflects at the circuit level and at the neurotransmitter level. So you'll see some familiar systems here: cholinergic, glutaminergic, dopaminergic, noradrenergic, etc. We're not relearning from scratch, okay? The goal is to connect mechanisms to prescribing decisions, especially when the evidence is limited or mixed. Also, we're going to touch briefly on APOE genotyping, not to turn you into a genetic counselor, but so you understand what information can and cannot responsibly guide you in your clinical practice. And when we talk about cognitive dysfunction theories, we're going to discuss developmental versus state-based versus neurodegenerative. The key question is always the same. Is this a fixed vulnerability, a reversible process, or a downstream effect of something else? So throughout this discussion, I'm going to refer us to the RDoC framework as a conceptual map, not because it's perfect, but because it helps us avoid reflexively equating symptoms with diagnosis. So keep this in mind. Mechanism first, medication second. And that's the through line for everything that's going to follow this lecture. Now, this slide introduces the organizing framework that we'll keep returning to. So rather than starting with DSM diagnoses, RDoC asks us to think in terms of functional domains, most notably attention, memory, and executive function, because those domains cut across the diagnoses regardless across the lifespan. Now, clinically, these functions are not abstract, and they depend on the very integrity of the circuit controlling them. So, prefrontal cortex, anterior cingulate, hippocampus, and they're distributed through the parietal networks. Now, when those circuits are disrupted by neurodegeneration or vascular disease, inflammation, medication, or chronic psychiatric illness, cognition is a symptom that can suffer, the process that can suffer. Now, the key shift here is subtle but important. We stop prescribing to labels and we want to start our prescribing to domains. So instead of asking the question, what diagnosis is this? We have to ask what cognitive system is impaired and what neurochemical lever might realistically help. Now, that's the practical goal here. So what we want to do is identify the impaired domain first, and then consider whether there's a reasonable neurotransmitter target. Or, just as importantly, if there is not a reasonable neurotransmitter target. So this framework doesn't promise you any sort of dramatic improvement, but it tries to give you a guide for precision and restraint and safe prescribing in a cognitively vulnerable person. So let's zoom out into the attention domain, which is often the first cognitive system that people try to treat. And just as often, we tend to misattribute. So from a circuit perspective, attention is not one thing. It's distributed. The prefrontal cortex handles the executive control, right? The anterior cingulate monitors the conflict and effort, and the parietal networks help orient attention in space toward the stimuli. So neurochemically, we're talking about things like norepinephrine as the primary driver, and dopamine plays that secondary modulator role, especially in the prefrontal cortex. But attention problems are not automatically dopamine problems. You see, the distinction matters clinically. What this looks like at the bedside is impairment in sustained, selective, or divided attention, and you see that pattern across diagnoses. So in ADHD, that's the classical sustained attention deficit, right? In depression, you will see it's slowed concentration and increased mental effort. In schizophrenia, it's often selective attention, difficulty filtering out relevant from irrelevant stimuli. That important takeaway is similar symptoms do not imply the same mechanism, and treating attention without understanding that underlying driver is how we end up over-prescribing stimulants or missing better targets altogether. So we'll come back to this domain later when we talk about attention complaints should not trigger stimulant treatment. Now, when we talk about memory in psychopharmacology, we're not talking about a single function. We're talking about a distributed system with different neural jobs. Some neural substrates, for example, the hippocampus and the medial temporal lobe, are central for encoding and consolidating episodic memory, new facts, new experiences, etc. The prefrontal cortex, though, is critical for working memory, that is, holding information online and manipulating it and using it to guide behavior. Clinically, this distinction matters because different disorders and different medications hit these circuits differently. Now, some key neurotransmitters include acetylcholine. ACH is the workhorse of encoding. So when ACH signaling is strong, the brain is in the learning mode. Glutamate, acting through NMDA receptors, underlies long-term potentiation, the synaptic strengthening that makes memory stick. If NMDA signaling is disrupted, learning becomes inefficient even if attention looks intact. So pay attention, remember, to your dementia patient who looks like they have it and they can front really well, but nothing's registering. So in Alzheimer's disease, early pathology will often target the hippocampus with prominent acetylcholine losses, which is why episodic memory tends to go first. In ADHD and schizophrenia, the issue is less about encoding new memories and more about working memory dysfunction. And that's driven by dopamine dysregulation in the prefrontal cortex. So that's why stimulants can improve working memory in ADHD, but won't restore hippocampal memory loss in Alzheimer's. So when a patient says, my memory is bad, your first question should be, is this an encoding problem or a consolidation problem or a working problem? See, this distinction should guide both the diagnosis and the medication choice. All right, let's talk about executive function. This is the brain's command and control center, right? This is the domain that determines whether intentions actually turn into behavior. Now, there's some major neural substrates here. The first is the dorsolateral prefrontal cortex, the DLPFC. This is responsible for planning, sequencing, and memory manipulation. That is, holding a plan in mind and executing it step by step. The orbitofrontal cortex, the OFC, evaluates reward, punishment, and social appropriateness. So this is where impulse control and decision-making under uncertainty live. The basal ganglia, that acts as a gating system, and that's deciding which actions, thoughts, or impulses are allowed through and which are suppressed. So executive dysfunction is rarely about one structure failing. It's about poor coordination across these networks. And dopamine modulates that gating and updating. So it modulates what information matters right now. Too little dopamine and you'll see sluggish initiation and poor working memory. If you have too much dopamine, you'll have distractibility, impulsivity, or even psychosis. Norepinephrine improves that signal-to-noise ratio. It sharpens focus and enhances the inhibition, but excessive norepinephrine shifts the brain into threat mode and worsens the executive control. So this is why optimal executive function depends on balance, not maximization. So key cognitive functions and clinical targets around planning and sequencing. So the question is, can the patient map steps from intention to action? And with respect to organization, you're asking the question, can they manage time, tasks, and priorities? And with respect to cognitive flexibility, can they shift strategies when something isn't working? And then with respect to impulse control, can they pause before acting? So in ADHD, for example, executive dysfunction reflects this inefficient dopamine and norepinephrine signaling in prefrontal circuits. In mood disorders, executive function often worsens during depressive or manic states. So even when attention looks intact, well, in something like substance use disorder, you'll see an impaired orbitofrontal cortex and basal ganglia signaling biases, decisions towards like short-term reward over long-term consequences. So this is why stimulants and atomoxetine and alpha-2 agonists, atomoxetine being an SNRI, they can improve function even when the symptoms don't fully remit. So executive dysfunction explains why patients may be motivated but still unable to follow through. So when a patient says, I know what I should do, I just can't do it, you're almost always in this domain of executive dysfunction. Now, projection pathways. There's cholinergic neurons do not carry specific content. Instead, they modulate how efficiently information is processed across cortical circuits. So think of acetylcholine as improving the signal-to-noise ratio, making relevant inputs stand out while suppressing background noise. And this is why cholinergic disruption produces these diffuse cognitive symptoms rather than a focal deficit. The functional role of acetylcholine is critical for attention regulation, learning, memory encoding, especially new information. So in the hippocampus, acetylcholine supports encoding over retrieval, helping form new memories rather than recalling old ones. So clinically, this explains what patients with cholinergic deficits struggle most with, which is new learning, not remote memory. So in Alzheimer's pathology, there is an estimated 40 to 90% loss of cholinergic neurons in the nucleus basalis of the mynard. So this results in profound acetylcholine deficits across the cortex and hippocampus. So importantly, this is not the primary disease mechanism. It's the downstream amplifier of cognitive symptoms. This distinction matters for how we think about treatment. So cholinesterase inhibitors, for example, do not stop neurodegeneration. What they do is they temporarily increase synaptic acetylcholine to optimize the remaining circuitry. So this is why benefits are very modest and time limited and often just symptom focused rather than disease modifying. So when cognition feels foggy or fragmented or effortful, especially for attention and new learning, think about cholinergic tone. And remember that treating the cholinergic system is about supporting function, not reversing pathology. Now, when clinicians talk about anticholinergic effects, what we're really talking about is which muscarinic receptors are being blocked and where. So all 5 muscarinic receptors, M1 through M5, are G protein coupled receptors. Now they differ by location, function, and clinical consequence when blocked or stimulated. So this slide is not about memorization, it's about predicting effects when you prescribe or deprescribe medications. Notice M1, cognitive receptor. Now this are concentrated in the central nervous system, especially in the cortex and hippocampus. M1 supports things like memory, learning, and higher order cognition. Clinically, M1 is the receptor we care about most in dementia. Anticholinergic burden worsens cognition because it blocks M1 signaling. So this explains why medications like diphenhydramine or oxybutynin can precipitate delirium, especially in older adults. So if a drug blocks M1, cognition will pay the price. M2 is a cardiac receptor. M2 receptors are prominent in the heart and some central nervous system. And the primary role is parasympathetic braking. So M2 is responsible for slowing the heart rate and reducing contractility. So when you increase acetylcholine, such as with a cholinesterase inhibitor, like say donepezil, you can unmask bradycardia or syncope. This is why baseline heart rate, conduction disease, and beta blockers matter a lot in treating somebody with dementia. M3 is a peripheral side effect receptor, and that typically dominates in areas of smooth muscle, exocrine glands, and some CNS regions. M3 will mediate things like salivation, GI motility, and bladder contraction. If you block M3, you'll get this classic triad of dry mouth, constipation, and urinary retention. So that's why some drugs are marked as bladder selective will still cause dry mouth, because true selectivity is really imperfect. The M4 dopamine modulator is found in the basal ganglia and striatum. They don't drive cognition directly. Instead, they modulate dopamine release and motor control. So this is clinically important because what you'll see is M4 is now a therapeutic target in schizophrenia. Drugs like xanomeline, which is a combination therapy, the new drug called Cobenfy, that's here to indirectly reduce that dopaminergic overactivity. This represents a major shift from pure D2 blockade. This is cholinergic psychiatry, not old school antipsychotics. And then finally M5, which is the reward and addiction pathway located in the midbrain, including the substantia nigra. These things influence dopamine release in the reward circuits. So M5 is not yet a routine drug target, but there is emerging research focusing on it for addiction and reward-based disorders. So this receptor is about where the science is heading, not what you prescribe today or tomorrow. So when you evaluate medications, you have to ask the question, which muscarinic receptor is affected? And is cognition, heart rate, bladder function, or reward processing most at risk? So this receptor-based thinking will explain things like anticholinergic burden scales, delirium risk, and why newer agents try to be functionally selective, not globally cholinergic, right? The brain doesn't experience side effects, it experiences receptor effects in context. All right, let's talk about glutamate. This is the brain's primary excitatory neurotransmitter. And the NMDA receptor sits at the center of learning and memory. So under normal conditions, NMDA receptor activation allows calcium influx only when neurons are appropriately depolarized. Now that calcium signal is what drives long-term potentiation, the cellular basis of learning and memory. So at baseline, NMDA receptors are not just on switches, they are coincidence detectors. They require the right timing, the right voltage, and the right amount of glutamate. That precision is what allows learning without injury. Now, look at the pathology panel. So when glutamate levels are chronically elevated, or when NMDA receptors are tonically activated, you lose that precision. Calcium influx becomes excessive and sustained, and then this leads to excitatory mitochondrial injury and oxidative stress, and ultimately neuronal death. So this mechanism is implicated in conditions like Alzheimer's disease and traumatic brain injuries and stroke, and potentially some aspects of schizophrenia and neurodegeneration. Importantly, this is why this is a known biological failure mode. This is not just hypothetical risk. Now, the key psychopharmacology insight in this green box, memantine does not simply block NMDA receptors. If it did, it would impair learning. Instead, memantine selectively blocks that pathologic tonic activation while preserving the physiologic phasic signaling. So in other words, it dampens noise without eliminating signal. And that distinction matters clinically because patients will often ask why a drug like memantine produces only modest benefits rather than dramatic improvement. The answer is not we're enhancing memory. We're just preventing further damage while preserving what remains. So this slide also helps explain why many psychotropic medications unintentionally affect cognition. Any drug that indirectly alters glutamate tone through dopamine, GABA, or acetylcholine is going to shift this balance. So the takeaway here is simple. Cognition depends on excitation, and that's precisely regulated. So too little NMDA activity is going to impair learning, and too much is going to destroy neurons. And psychopharmacology in this domain is never about turning receptors on or off. It's just about protecting the conditions under which learning can still occur. So we've established that cognition depends on precisely regulated glutaminergic signaling. Now, NMDA receptors are essential for learning, but when they're tonically overactivated, they become neurotoxic, and this is the biological tension at the heart of neurodegeneration. So the pharmacologic question is not how do we boost cognition, it's how do we protect neurons without shutting learning down. That's where the memantine comes in, right? So memantine is not a cognitive enhancer in the way that students will often imagine. It doesn't increase intelligence or memory or processing speed. Instead, it acts as a voltage-dependent, uncompetitive NMDA antagonist, which is a very precise way of saying it only blocks the receptor when it's pathologically overactive. In normal synaptic firing, those brief phasic signals that underlie learning, memantine disengages quickly and allows signaling to pass through. But in disease states where glutamate tone is persistently elevated, memantine sits in the channel and prevents chronic calcium influx. So clinically, this means we're not reversing Alzheimer's disease. We're slowing downstream injury and preserving remaining neural networks by buying functional time. So this framing matters for patients and when you counsel them because you're going to set realistic expectations. Memantine is indicated in moderate to severe Alzheimer's disease, and it is often combined with a cholinesterase inhibitor. Not because the effects are dramatic, but because they act in complementary systems. Acetylcholine is to support encoding and attention. Glutamate modulation is to prevent further damage. So as we go through this slide, keep one thing in mind. This drug exists because too much excitation is just as harmful as too little. And psychopharmacology here is not about activation, it's about restraint and timing and protection. All right, let's now shift from glutamate to dopamine. But notice we're still talking about the same problem, signal versus noise. The mesocortical dopamine pathway projects from the midbrain into the prefrontal cortex. And in this pathway, this is the central method of working memory and sustained attention and executive control. And dopamine here is not about pleasure or reward, it's mesolimbic dopamine. This is about cognitive efficiency. So in the prefrontal cortex, dopamine acts like a turning knob. Too little dopamine, and neural firing becomes noisy and unfocused. Too much dopamine, and the network becomes rigid or overloaded. So optimal cognition lives in the middle of that curve, and this helps explain ADHD pathophysiology. In ADHD, we're not dealing with excess dopamine. We're dealing with dopamine hypoactivity in prefrontal regions. So this results in the impaired focus and poor impulse control and difficulty sustaining goal-directed behavior. Well, contrast that with what happens when we block dopamine. Think D2 receptor antagonism, especially with older, high-potency, typical antipsychotics. It doesn't just reduce psychosis. It can slow processing speed and impair executive function and blunt motivation. This is one reason patients often describe feeling cognitively dulled or slowed on certain antipsychotics. So again, we're back to trade-offs, right? Stimulant medication work not by flooding the brain with dopamine, but by enhancing synaptic dopamine availability, specifically in the prefrontal cortex. It improves that signal-to-noise ratio, strengthening task-relevant signals, and suppresses background noise. So clinically, this is why stimulants can improve focus and working memory in ADHD, but also why misuse or overdosing can push patients past that optimal range and worsen anxiety and rigidity and impulsivity. Now, as we move into medications, keep this in mind. Dopamine is not good or bad, it's contextual. And our job is not to maximize it, but to place it where and when cognition actually benefits. Well, if dopamine is the turning knob for cognitive precision, and norepinephrine is going to be the arousal gatekeeper. Now, the primary source of central norepinephrine is in the locus coeruleus, right? A small but powerful nucleus in the brainstem that projects widely into the cortex, the limbic system, and especially into the prefrontal cortex. Norepinephrine regulates arousal and vigilance and sustained attention. It determines whether the brain is alert enough to engage with information or overwhelmed and scattered by it. So in healthy cognition, norepinephrine helps maintain focus over time, and it supports task engagement and readiness to respond to a salient stimuli. But like dopamine, this system follows an inverted U-curve. So too little norepinephrine and the patient looks disengaged, inattentive, mentally fatigued. But too much norepinephrine and then the person shifts into fight or flight mode and hyperarousal and anxiety and emotional reactivity and impaired executive control. This is highly relevant in ADHD. In ADHD, norepinephrine dysregulation in the prefrontal cortex contributes to distractibility and poor impulse control and difficulty sustaining attention, especially under stressful cognitive load. Now notice how different this is from simply low energy or a lack of motivation. This is not a character flaw. This is a circuit level regulation problem. Pharmacologically, alpha-2 adrenergic agonists, such as guanfacine, work by strengthening prefrontal cortical networks, and they reduce the background noise and enhance the signal fidelity by stabilizing that neuronal firing in the prefrontal cortex. Unlike stimulants, though, these agents do not increase catecholamine release globally. Instead, they will optimize that prefrontal signaling, which is why they are particularly useful for things like impulsivity and emotional dysregulation and hyperarousal, especially in patients who cannot tolerate stimulants. So again, this pattern holds. Dopamine's here to refine that precision, and norepinephrine is regulating that readiness. And cognition emerges when both systems are balanced, not maximized. So as we continue into the medications, keep asking that same question. Are we trying to increase signal, reduce noise, or calm an overactivated system? Now this slide is not about certainty. This is about risk assessment. APOE is a gene that helps the body move cholesterol and fats in the brain. And everyone has 2 copies of this gene, one from each parent. And there are 3 common versions, E2, E3, E4. Now, the versions do not mean someone will or will not get Alzheimer's disease. They simply change the probability. Now let's walk through this. So E2 is considered protective. People with at least one E2 copy tend to have a lower lifetime risk of Alzheimer's disease. If they do develop this disease, it's often later in life. So think of E2 as a protective factor, not immunity. Now E3 baseline, most common, this is the most common genotype, E3, found in about 60% of people. It represents average risk, which is about 10 to 15% lifetime chance. This group is used as the reference point when you start to compare average risk versus higher risk. And average risk, by the way, does not mean safe. It does not mean high risk. It just means typical. E3, E4 is moderate risk increase. Now, people with one copy of E4 have a 2 to 3 times higher risk compared to average risk E3, and many people with this genotype will never develop Alzheimer's, but the risk is clearly higher. This becomes especially important when considering new Alzheimer's medications because E4 carriers have a higher chance of treatment-related brain swelling and bleeding. When we get to those new infusion medications, those monoclonal antibodies. But just keep that in mind. E4 carriers have a higher chance of treatment-related brain swelling and bleeding. Now, E4, this is high risk. This is the highest risk group, but it is also rare. About only 2 to 3% of people have 2 E4 copies, and this increases the risk from 8 to 15 times average and is linked to earlier onset symptoms. So even here, risk is not a certainty. Some people with this genotype will never develop the disease. So the big picture here is that genes load the gun, but epigenetics such as lifestyle, health, and environmental, they pull the trigger. So APOE testing helps you only understand risk and try to plan monitoring. It can guide treatment decisions. It does not diagnose Alzheimer's, and it does not predict the future. This is about informed decision-making, not fear-mongering and coercion. So this slide answers a very practical question. Just because we can test, should we? Now, genetic testing is only useful if it's going to change what you're going to do clinically. So when should you consider testing? Well, if there's a strong family history. If a patient has early onset Alzheimer's in the family of multiple first-degree relatives, then APOE testing can help frame risk discussions and long-term planning. Now, this is about context, not diagnosis. So in mild cognitive impairment, MCI, in patients with an APOE status, this can help stratify risk. That is to say, who is more likely to progress to dementia versus remain stable. It does not confirm Alzheimer's, but it informs prognosis. So some patients explicitly want genetic information for future planning. They want to know about finances, housing, caregiving decisions. And testing is reasonable only if the patient understands the limits of what the results mean. Now, what about anti-amyloid therapy workup? This is currently the most concrete indication. So APOE, E4, as I said, especially if they have E4, have a higher risk of ARIA. What's ARIA? Amyloid-related imaging abnormalities like brain swelling or bleeding. Here, the testing directly affects treatment eligibility and monitoring and consent. when should you avoid testing? Well, avoid testing asymptomatic low-risk individuals because testing someone with no symptoms and no strong family history often will cause anxiety without benefit. There is no proven prevention strategy that changes based solely on APOE status. The other thing to keep mindful of is insurance and discrimination concerns. Genetic results will affect life insurance and long-term care insurance ability to purchase and be included. So that Genetic Information Non-Discrimination Act, by the way, GINA, does not cover everything. This is one of those things. And advanced dementia, if a patient already has advanced disease, then APOE results are unlikely to change management or outcomes, and it will not impact the plan of care. So if a patient or family would not pursue disease-modifying therapy regardless of risk, then testing adds information but doesn't add any value. So APOE testing is not a screening test. It's a decision support tool. So before ordering this, please ask, will this change medication treatment? Will this change monitoring? Is this going to change planning? And can the patient emotionally and practically handle the result? If the answer is no to any of those, then probably testing is not indicated. Ethical testing is not about how much information we can generate. It's about how much information is useful. And that distinction is part of being a good clinician. You're not just a plug-and-chug psychiatric nurse practitioner or technician. Now, this slide is about how a gene result can influence real treatment decisions. Not because it guarantees disease, but because it changes risk and strategy. So, for example, cholinesterase inhibitors, right? Donepezil, rivastigmine, galantamine. Think of these medications as symptom helpers, not cures. So people who already carry APOE4 tend to decline faster on average once the symptoms begin. So because of that, clinicians may consider starting these medications earlier, even at the stage called mild cognitive impairment. And the goal is not to stop Alzheimer's in this case, but to support memory and thinking sooner before the symptoms worsen. So APOE4 doesn't force treatment, but it can shift maybe the timing toward earlier symptom management. Now, with respect to anti-amyloid therapies, right, Leqembi and Kisunla, these drugs are different. They target amyloid plaques, which are part of Alzheimer's biology. So APOE4 carriers, especially people with the 2 copies of the E4, have this much higher risk of side effects, ARIA, right? So ARIA can involve brain swelling and small brain bleeds, which is why this matters, because you now have to stratify risk before starting treatment. And patients need very clear counseling about the benefits versus the risks. Now, these patients that undergo this treatment are going to need frequent MRI scans. It's required, especially for high-risk patients. And APOE4 doesn't automatically rule out the drugs, but it does raise the bar for monitoring and informed consent. Now, another thing to keep in mind is this cardiovascular risk management. So, APOE4 is not only linked to Alzheimer's, but also higher vascular risk, heart disease, and stroke. So blood pressure, cholesterol, and blood sugar directly affect the brain. So for an APOE4 carrier, you may want to push harder for blood pressure control and treating the cholesterol aggressively and preventing or treating the diabetes carefully, because protecting the blood vessels helps preserve that cognitive reserve and the brain's ability to keep functioning despite disease. So APOE4 does not tell us who will get Alzheimer's. It does not tell us when it will happen or how severe it will be. What it does tell us is who needs closer monitoring, who needs more careful risk discussions, and who may benefit most from preventative and supportive strategies. So now we're going to move on to neurodevelopmental models, including something like when someone has a psychotic break. We're going to look at it like a lifelong neurodevelopmental condition rather than a flash in a point of time. And this will show early through cognition who may be progressing along this path. So often in schizophrenia, you will notice that the cognitive deficits come first. And one of the most important ideas here is that of timing. In schizophrenia, cognitive problems often appear years before the psychosis. So that includes things like difficulty with attention and working memory and processing speed and executive function. And what's striking is that these deficits tend to be stable over time. They don't just suddenly appear when the hallucinations begin. So psychosis is not the beginning of the illness. It's often the most visible part of it, but it's not the first part of it. So if you wait for hallucinations to think about cognition, you're already too late. So first, do no cognitive harm. So because cognition is already fragile, medications that worsen cognitive function matter more in schizophrenia than in any other primary disorder. And typical antipsychotics, which strongly block D2 receptors, and slow thinking and worsen executive function and flatten motivation and processing speed. And on top of that, they come with an anticholinergic burden, whether from medications like benzodiazepines or polypharmacy, that further impairs memory and attention. So in schizophrenia, symptom control should ideally not come at the cost of making cognition worse. So I mentioned earlier this xanolamine trospium, a brand name Cobenfy, which came to market last couple of years. It targets the muscarinic and acetylcholine receptors, specifically M1 and M4. These receptors are involved in cognition, learning, and cortical regulation. The idea is to reduce the psychotic symptoms without relying on heavy dopamine blockade, which has historically come with those cognitive trade-offs. So this really represents a shift from how much dopamine can we block to how can we stabilize psychosis while preserving brain function. So why this matters is because cognition determines whether patients can work and learn and live independently and engage in treatment, not just that the voices are quieter. So schizophrenia conceptualizes it as a brain development disorder with early and persistent cognitive impairment. Now, where medication choices have long-term functional consequences. So if you treat psychosis but ignore cognition, you haven't really treated the whole illness. Now, this slide here is meant to reset your thinking and prevent you from overgeneralizing. Not all cognitive impairment means the same thing. So cognition as a state, not a trait, is what I want to drive home to you. So in major depressive disorder, cognitive impairment is usually state dependent. That is, patients will commonly report poor concentration and slow thinking and trouble with planning and decision making. But crucially, these problems tend to track with the mood severity. But when the depression improves, cognition often will improve as well. So that's a very different picture than someone would say schizophrenia, where the cognitive deficits appear early and then persist across time and do not fully normalize with symptom control. So depression fog, that's often reversible. Schizophrenia cognition is often not. It's enduring. So the prescribing implications, that is to say, you want to treat the mood to fix the brain, because cognition is tied to mood state, and the primary strategy is to treat the depression effectively and decisively. And partial treatment often leaves patients saying, I'm less sad, but I still can't think clearly. And that usually means that the mood disorder is not fully treated, not that cognition is a separate disease process. So don't chase cognition first, fix the depression well, and then the cognition will often follow. Now, there are some pro-cognitive antidepressant choices. Some antidepressants are more helpful for cognitive symptoms than others, and some examples include things like bupropion, which enhances dopamine and norepinephrine signaling and often will improve things like energy and focus and mental speed. Vortioxetine, Trintellix, which has multimodal serotonin effects and evidence for improving things like processing speed and executive function and that subjective complaint of brain fog. This is especially useful in patients whose main complaint is, I'm depressed and my brain feels offline. Now, there are some medications to minimize or avoid. Not all antidepressants are equal when cognition is a concern. highly sedating agents, strong anticholinergic medications, and things like high-dose paroxetine, which hopefully goes out of favor, and older adult tricyclics antidepressants. Now, these things can improve mood, but they typically will worsen attention and memory and clarity. So a patient will say to you, I'm less depressed, but I feel dull. That's not a prescribing, that's a prescribing problem. So not a patient problem, and so you should know that. So depression-related cognitive impairment is often episode-linked, it's reversible, highly medication-sensitive. In depression, cognition improves when the brain state improves. So your job is to choose the treatment to lift the mood without clouding the mind. So up until this point, we've talked about two models. We've talked about depression, which is cognition is mostly state dependent, and schizophrenia, in which cognition is largely this neurodevelopmental and stable, enduring condition. Bipolar does both, and that's why this is clinically tricky. So trait hypothesis with respect to cognitive vulnerability is that it's always there. But the trait hypothesis also proposes that people with bipolar disorder have this baseline cognitive vulnerability even when the mood is stable. So even during euthymia, when the patient looks well, there may be chronic subtle deficits in attention, executive function, processing speed. So if a patient says, I'm not depressed or manic, but I still don't think like I used to, that complaint deserves to be taken seriously. This is not just residual mood. It's probably part of that illness architecture. So there's a scar hypothesis, and this is that episodes leave damage behind, right? So the scar hypothesis adds this second layer. It's the idea that each mood episode leaves a mark. Every manic episode, every depressed episode. And recurrent mania and depression are considered neurotoxic over time. And so that those cognitive deficits may accumulate when the episodes burden. That process is also often called neuroprogression. So in plain terms, that's to say, the more episodes a patient has, the harder it is for cognition to fully bounce back. So that's why early effective mood stabilization matters, not just for symptom control, but for long-term brain preservation. That's the working theory. So if cognition is a priority, and in bipolar disorder it should be, then medication choice matters a lot. So this is where things like lamotrigine, right, because it has minimal cognitive slowing, often is described by patients as clear or neutral, particularly helpful for bipolar depression and maintenance. The problem is the titration is very slow and we're time crunched, and so it doesn't get used until very late. You want to use caution in drugs like topiramate, right? Because Topamax, also known as Dopamax sometimes for a reason, and valproate, especially at the higher doses. These agents can slow processing speed and impair leading to word finding and worsening executive function. Even if the mood is controlled, patients may feel stable but dulled. So this mental map to move forward would be things like depression, cognition is state linked, so you treat the mood, cognition improves. Bipolar is trait and scar, so you want to protect cognition early and long term. And then schizophrenia, cognition is a core and enduring, so you want to minimize the iatrogenic harm. And in bipolar disorder, cognition is not collateral damage, it's part of the disease course. So every untreated episode is not just a relapse, but potentially a cognitive injury, and your prescribing decisions today may shape the patient's future thinking capacity, their occupational function, and long-term quality of life. Okay, let's deal with ADHD. So ADHD is different. This is not a disease of cognitive loss. This is more cognitive regulation problem. And everything we just reviewed with respect to the prefrontal cortex and dopamine and norepinephrine and signal-to-noise balance comes together most cleanly here in ADHD. So in ADHD, the brain has the cognitive capacity, but it struggles to engage it consistently, especially for things like sustained attention and working memory and impulse control and executive organization. So this is why ADHD is often described as knowing what to do but being unable to do it reliably. So we want to reframe stimulants before we start, before we even talk about the medications. Stimulants are not about speed or energy or revving up the brain. They're about restoring signal clarity in the prefrontal cortex. So in ADHD, the problem is not too much dopamine. It's not enough where it matters. So this section is going to focus on how we can do this very practically. Stimulants versus non-stimulants. Mechanistically, not based on the brand name. And how to select a medication based on the patient presentation, not habit. And how to manage tolerance without reflexively escalating doses. And how to think clearly and safety about monitoring and misuse risk so that you're prescribing with intention and not just like pattern recognition checking boxes. So as we move through this section, I want you to think about ADHD medications not as performance enhancers, but think of them like prosthetics for executive function. And your job is going to be to restore function and minimize collateral harm and help patients build lives that work, not just symptoms that look better on a checklist. Now this slide's important because the entire ADHD section, many clinicians will be tempted to unknowingly just start prescribing by brand name instead of mechanism. So let's take a look here. We have methylphenidate and amphetamines. And these are effective treatments for ADHD, but they're not interchangeable. These differ in mechanism and subjective experience and risk profile, and how forgiving they are when the diagnosis or dosing is not perfect. You need to really understand the distinction and what separates intentional prescribing from just trial and error, which is fairly standard in psychiatry, unfortunately. So why these drugs feel different? So methylphenidate works by blocking reuptake of dopamine and norepinephrine. Think of it as a let's keep more of what the brain has already released. It does not force neurotransmitter release. So this creates a smoother, more physiologic effect, especially in the prefrontal cortex. Amphetamines, on the other hand, these are block reuptake and increase release of dopamine and norepinephrine. So in plain language, we're actively pushing neurotransmitters out into the synapse. So that's why amphetamines often feel stronger and longer lasting, and also why they carry more risk. So what patients actually report on methylphenidate is often things like clearer thinking, better task initiation, less emotional intensity, less buzziness, less euphoria. And that's why methylphenidate is often better tolerated if the patient has anxiety or some mood lability, in patients that are sensitive to overstimulation. Patients on amphetamines may report this stronger focused, more sustained energy, greater productivity, but they're also going to report higher incidence of appetite suppression, insomnia. You'll notice more irritability and emotional flattening if they're overdosed. So onset and duration also is not just a convenience issue. Duration matters clinically, and longer is not automatically better. So a medication that lasts 14 hours can improve work performance, but worsen sleep and appetite and emotional recovery. Vyvanse is highlighted here because it's a prodrug. It has to be metabolized before becoming active. So this lowers, not completely, but it lowers abuse potential and rapid spikes and euphoria, but it does not eliminate the risk. Now, abuse potential is a reality, not a moral judgment. Methylphenidate has moderate abuse potential. Amphetamine has higher abuse potential, with Vyvanse being the partial exception due to that delayed activation. This matters most when your diagnosis is uncertain, there's a history of substance use, or monitoring is inconsistent. The reason methylphenidate is usually first line is because it's more forgiving and easier to titrate, and it's less likely to overshoot dopamine tone. So in other words, if the diagnosis is right, but the dose isn't perfect, methylphenidate is less likely to cause harm. Amphetamines work well too, but they require more precision. So the main takeaway is ADHD stimulants are not about strength, they're about fit. And the right medication is the one that restores that executive function and preserves an emotional range, and also allows the patient to live their fullest life, not just focus harder. One of the complications of these medications is erectile dysfunction, so that is a reason that people will have a hard time with these medications long term. So there's an important distinction here to make about half-life. It's understood to mean duration, but it's not. Half-life is not duration. So the answer to two completely questions. Half-life tells you how long it takes the body to clear the drug. Duration tells you how long the patient actually feels the benefit. So if you dose these drugs based on half-life alone, you will make some bad prescribing decisions. So this confusion happens because people just assume that a short half-life equals short effect. And that's often wrong, especially with the modern stimulant formulations. What actually determines the duration is the delivery system, the release kinetic, and the prodrug status, not just the clearance. So think of Concerta, the prototype for methylphenidate ER. Methylphenidate itself has a short half-life, about 2 to 4 hours. But Concerta has this osmotic releasing system. So that means the drug is released slowly and steadily throughout the day, even though each molecule is cleared quickly. So clinically, this can give you about 12 hours of effect with a smoother curve, fewer peaks and crashes. So short half-life does not mean short coverage. Vyvanse, lisdexamfetamine here, is a prodrug. This has to be converted in the bloodstream into active dextroamphetamine. That conversion process then is slowing the onset, but extends that half-life to roughly 9 to 13 hours, but it produces that 10 to 14-hour clinical effect. So that's why things like Vyvanse will feel smoother, less spiky, harder to abuse. But again, it's about the design, not the metabolism. So the clinical mistake to avoid is do not say this drug has a long half-life, so it must last all day. And do not say this drug has a short half-life, so it'll cover school hours. Those are assumptions that can be wrong more often than they're right. So the right question to ask is this: what coverage does this patient actually need? School day only, school plus homework, workday and evening symptom rebound, sensitivity to late-day appetite suppression or insomnia. And then you're going to select formulation, release mechanism, and timing, not half-life alone. Half-life tells you clearance. Duration tells you function. You want to prescribe for function. So let's look at this case here. We have a 9-year-old girl, Stephanie Lee, who presents with the classic inattentive ADHD. Now, her teacher's reporting daydreaming and incomplete assignments. She forgets instructions. But what's notably absent, and also as important, we're not getting reports of hyperactivity, impulsivity. That matters because inattentive ADHD is often missed, especially in girls, and frequently misinterpreted as anxiety, low motivation, or immaturity. The parental context is also very important because this parent is worried about stimulant, side effects, stigma, and the idea of their child being medicated at school. So that tells us something critical. Medication choice here is as much about trust and counseling as it is about pharmacology. So medication selection. We're choosing methylphenidate ER Concerta starting at 18 milligrams once daily in the morning. This is not an aggressive choice. It's very deliberate. Why methylphenidate? Well, there are 3 main reasons. First, tolerability. Methylphenidate is generally better tolerated in pediatric patients than amphetamine products, especially in the areas of appetite, mood lability, and emotional flattening. Second is this delivery system of that osmosis releasing technology, which gives us that smoother gradual rise, no sharp peaks, and less afternoon rebound. That directly addresses the parent's concern about side effects. And third, there's this practical stigma reduction. So this formulation covers the full school day and does not require the nurse to give medications. And it keeps the child from being singled out. So that's essentially a good approach to developmental. You can give it in the morning before they go to school. Now, for inattentive ADHD specifically, methylphenidate has this robust evidence for cognitive focus, and it improves without increasing behavioral activation, because here we're primarily targeting attention, not suppressing energy that isn't excessive to begin with. So what do you need to do? This monitoring situation to build trust is essential. So you want to track height and weight every 3 to 6 months. You want to encourage a protein-rich breakfast before taking the medication, right? And we don't tell parents, don't worry about appetite. You need to give them a plan. And if you're not up for this, then pair them with a nutritionist. The other thing is you want to give this dose before 10 a.m. because if insomnia appears, all we're going to do is just adjust the timing or the formulation, not blame the kid. Also, you need to pay attention to baseline heart rate and blood pressure and repeat these at follow-ups as routine, not alarmist things. And you want to use some scales to track efficacy, Vanderbilt scales, Conners, from both parents and teachers. And we measure this objectively, not just she seems better. You need multiple inputs in this. So I want you to remember, in inattentive ADHD, your first goal is clarity, not control. So choose medications that improve attention without changing who this child is. Now, the monitoring is super important, and what distinguishes a good clinician is what happens after that prescription is written. So the first thing is timing is key. We dose it early in the morning, ideally before school. Late afternoon dosing is one of the most common and preventable causes of stimulant-related insomnia. So if a child isn't sleeping, the first question is not, is this the wrong medication? It's what time are you getting this thing? The second question is nutrition. So you want to counsel for high-protein breakfast before dosing. Okay, not chase the appetite at lunch when the medication is peaking. So this reframes appetite suppression as something you can plan around, not something to ignore, which means you're going to have to plan in the morning to make sure there's enough time for breakfast, and maybe the parent's ADD is the problem here, not so much the child. So the third thing is also to set the expectation for side effects. Mild headache, stomachache is fine in the first 1 to 2 weeks, and it's common and it's usually transient. So if the family expects this, they're far less likely to panic or discontinue it prematurely. The middle column is the tracking protocol. So before starting, you document baseline weight, height, blood pressure, and heart rate. And then you want to look at rating scales. So you collect these scales from the parents, the teachers, because ADHD is a contextual disorder. If it's only better at home or only better at school, you're not dealing with ADHD, you're missing something else. There's some environmental dynamic thing. And then also follow-up timing. You want to reevaluate in 3 to 4 weeks, and that's long enough to assess tolerability and early efficacy, but short enough to adjust before utter frustration sets in. I bring them back in 2 weeks. You'll see some changes, but make sure they're the usual 2 weeks, not holiday week and then school week and then special events week, etc. So this column is where the clinical reasoning shows. So you start low at 18 milligrams, and if the response is inadequate after about 3 to 4 weeks, then you can titrate up to 27 and then 36. But you don't want to rush, and you don't want to jump to doses based on someone's impatience. The other thing is you want to consider formulation fit. Does the coverage last through the school day, homework time, etc.? If not, we don't automatically increase the dose. What we consider is whether a booster or a different formulation makes more sense. And finally, tolerance and monitoring. If efficacy fades over time, you need to reassess adherence and reassess expectations. And also, this is unpopular, but I strongly recommend weekend medication, holidays when appropriate, if possible, because that will resensitize their receptors and help with that poop out effect. Not every child needs a daily exposure, but that's an individualized decision, not some ideology to adhere to. And the monitoring is really how you're going to protect trust and growth and maintain sleep and prevent downstream harms. It works better when you're pairing this with structure and behavioral reinforcement, because the pills are not magical, and it helps if they can develop good habits now that they can while on the medication. All right, let's talk about this methylphenidate here in this case. So we have methylphenidate works primarily by blocking the reuptake of dopamine and norepinephrine. In other words, it keeps the existing neurotransmitter in the synapse longer, but it does not actively push out more. So look at this 14-year-old female with combined ADHD. She has what? Significant hyperactivity, impulsivity, and classroom disruption. And there's academic underperformance and so this is not an issue of under-treatment, right? She has been titrated up to this Concerta 54 milligrams with an inadequate clinical response. So the distinction matters. And by the way, this whole ADHD thing assumes that the diagnosis is correct. If you want to make the diagnosis properly, I'll refer you back to the 777 lecture when we talked about how to make the diagnosis. But this is assuming ADHD is correct. We're not dealing here with a non-adherence underdosing issue. What we're dealing with in this case is a mismatch issue. So the right column there, instead of pushing methylphenidate higher or stacking add-ons, the correct answer might be time to switch from methylphenidate to the amphetamine class. So this might be where you would consider Adderall XR 20 milligrams in the morning or Vyvanse 30 milligrams in the morning, because what you're trying to do is change the mechanism, not the dose. Now look at this bottom left corner here. This is that neurobiology driving decision making. Unlike methylphenidate, amphetamines do two things. Yes, they block the reuptake, but they increase the neurotransmitter release. This makes them more potent, especially for things like hyperactivity, impulsivity, and behavioral disinhibition. So that's why amphetamines often succeed where the methylphenidates will fail. And if there are concerns about misuse and diversion, then Vyvanse is preferred because of the prodrug, and it has to be metabolized to become active. That means the crushing and snorting is supposed to be not as easy to do. So this switch also requires a change in counseling. First, we need to pay attention to mood and irritability because amphetamines are more likely to cause that. They're also more likely to cause an end-of-day crash. So you need to warn families to monitor for affect, not just attention. These are also more likely to suppress appetite, so more pronounced here. So you need to proactively recommend protein-dense meals and scheduled snacks and work with a nutritionist if needed, and monitor the growth curves and make sure you set expectations cleanly. Make sure, ideally, puberty has started, because some people say this blunts the growth and eating and development, but it's an individualized decision and it's all going to be about trade-offs. So this medicine works differently. It may feel stronger. It doesn't mean it's unsafe. And methylphenidate failure is not stimulant failure. It's just a signal that you may need to change mechanisms, not abandon evidence-based care. Again, assuming the diagnosis is correct. So atomoxetine, brand name Strattera, this is a selective norepinephrine reuptake inhibitor. So unlike stimulants, it does not increase dopamine release, and it does not have immediate effects and no abuse potential. What it does is it increases norepinephrine at the prefrontal cortex, which indirectly improves attention, working memory, and executive control. This is a quieter, slower mechanism, and that matters more for both patients and what you're going to tell them, essentially. So this is best indicated, they would say, not as a first-line replacement for stimulants in most patients, but it can be a good strategic choice in specific situations, like when ADHD coexists with an anxiety disorder, where stimulants may worsen the jitteriness, or if they have an underlying tic disorder in which stimulants can exacerbate, or if there's a history of substance use disorder, because atomoxetine is not abusable. No one enjoys this that much. Or there's a stimulant intolerance, such as in severe appetite loss or insomnia. Now, this too will blunt appetite. SNRIs do have that effect, because you'll know from a previous lecture they're indicated for binge eating disorder. This has an indication also for binge eating disorder. So this is often a thoughtful second line or parallel track medication, not a fallback. So meaning you can use it first line, but the guidelines all say stimulants are first. Atomoxetine dosing is weight-based. So you typically start at 0.5 mg per kilo per day. That's for about 3 to 5 days. And then you can up titrate to 1.2 mg per kilo per day over a 2 to 3 week period. There is a ceiling. The ceiling dose is that 100 milligrams or 1.4 mg per day, whichever comes first. This is not a medication you rush through. This is not a fast titration because you'll increase side effects without improving outcomes. It requires an acclimation period like all the other SNRIs do. This is the most important thing to tell people is it does not necessarily work right away. Now, they may have a placebo effect right away, but 3 to 4 weeks before meaningful benefit. So sometimes even longer for full effect. They do find this more convenient, though, because it is refillable. So one of the downsides of the stimulants, depending on where you're practicing and the laws of the day, that may require a refill every month. So that's something to keep in mind. So there are no routine labs with this atomoxetine. Hepatotoxicity does occur, but it is rare. So if you want to do baseline LFTs and some sort of quarterly to semi-annual monitoring around dose adjustments, you want to watch out for jaundice, dark urine, right upper quadrant pain. If symptoms appear, then you check liver functions at that time. There is a black box warning on atomoxetine. There is an increased risk of suicidal ideation in children and adolescents, particularly in the first 4 weeks of treatment. That doesn't mean the medication's unsafe, but it does mean you need to monitor mood closely. This is the same black box warning on the SSRIs and other SNRIs, and you want to schedule early follow-ups and talk to the parents about this. It's not a reason to avoid the medication when it's clinically appropriate. So the way to think about this is it trades speed and potency for safety and stability and lower risk. It's not for every patient, but for the right person, this can be a good fit. All right, let's talk about guanfacine. So guanfacine is a selective alpha-2 adrenergic agonist. And in plain language, that means it does not stimulate the brain. It actually calms excessive signaling, and that strengthens that prefrontal cortex. So think of this drug as improving the brain's signal-to-noise ratio. It's helping the PFC filter impulses and emotional reactivity. So this is very different than how stimulants works. So this is especially helpful for if the driving complaint is hyperactivity, impulsivity, aggression, or emotional dysregulation. Intuitive is the brand. And it's also commonly used as an adjunct to stimulants, especially when they help attention, but it worsens irritability and insomnia. So this is the layering medication, not an replacement medication. So you typically start low at 1 milligram at bedtime, titrate it weekly by 1 milligram, and the max dose is 4 milligrams at bedtime. And if you give it at night, that helps you leverage that sedating effect and minimize daytime fatigue. Now, the most common side effect on this medication is sedation. Importantly, it's usually transient. And the other thing to watch for is bradycardia, hypotension, and occasional dizziness, so maintain adequate hydration with this as well. It's often why you check baseline blood pressure and heart rate, and then you recheck it during the titration period. This drug must never be stopped abruptly. If you stop it suddenly, you can get rebound hypertension, and sometimes it could be severe. So this needs to be tapered. So the decreasing schedule for tapering is 1 milligram every 3 to 7 days. So make sure they know that. If medication consistency is not going to be good in this family, then this is not the drug for you. So a good way to think about this is the stimulant sharpens the focus, the guanfacine quiets that impulsivity and emotional noise. So when ADHD looks more like dysregulation than distraction, this serves as a good, useful consideration. Now, this is a last non-stimulant drug we're going to cover here. This is viloxazine, also known as Quilibre. This is one of the newer options for ADHD, and it fills that very specific niche. So this medication is a selective norepinephrine reuptake inhibitor, a lot like atomoxetine, Strattera, right? But it's not the same drug. This, in addition to increasing norepinephrine in the prefrontal cortex, also has some serotonergic modulation. That serotonin piece is important because it helps explain why this medication can feel less activating than a stimulant, and it's often better tolerated in patients with a primary anxiety or comorbid anxiety disorder. So this medication, viloxazine ER, was approved in 2021 for children ages 6 and up and adolescents and adults, okay? Unlike some older non-stimulants, this one spans that full age range. So this is a lifespan drug here. And there are three main reasons people reach for this medication. First, it's the once daily dosing, which improves adherence, but so is atomoxetine, that's once daily. It's often a good fit for patients with comorbid anxiety, where stimulants may worsen or cause restlessness or irritability. And third, it's a non-controlled substance. That means no abuse potential, no DEA scheduling, it's refillable, there's less stigma because of timing. You don't have to be the kid who has to go to the nurse. And you usually start this low at 100 to 200 milligrams in the morning, and you're going to titrate this up to 400 to 600 milligrams daily. This is not a same-day effect medication, so you need to tell them this builds over time, same 3 to 4 weeks as the atomoxetine. And the most common side effect, because of that serotonin modulation and the norepinephrine reuptake, is that GI upset, some solemnity, and also there will be some decreased appetite. Usually mild to moderate, it will improve as they acclimate to the dose. So who should use this? Well, if atomoxetine feels too slow or too flat, or if a stimulant feels too activating, viloxazine often sits right in the middle. So it's not a first line for everyone, but for the right patient, especially one with anxiety or stimulant hesitancy, this could be a reasonable choice. One of the most common clinical questions you're going to hear in practice is, the stimulant worked and now it doesn't. So what do I do? And this is that evidence-based framework for answering the question. So the first framing point, tolerance is not addiction. And loss of response does not automatically mean the medication has failed. In most cases, what's happening is tolerance is reflecting receptor adaptation. So dosing strategy or formulation mismatch is a problem there. All of that is modifiable. So medication holidays, which are planned breaks, usually weekends or school vacations, can allow for partial receptor sensitization. Now, this is not appropriate for every patient, and you'll always weigh functional needs and emotional regulation and safety. But for some children, weekends off are reasonable. For others, continuous coverage is necessary, but that's an individualized decision. And the stimulants can be stopped without titrating. So those are okay. In fact, when they first came to market, they were only prescribed. They used to tell them in the beginning, only take this on school days, etc. Now we've gone to everyday dosing as the standard. Now, number two, the other thing you can do is a more medication is not always better. So dose optimization is key. Rapid escalation accelerates tolerance. So if your goal, as it should be, is the lowest effective dose, not the maximum tolerated dose as what's currently practiced. So if a patient is escalating at every visit, pause and reassess before pushing that higher. The other thing you could do is switch stimulant class. This is one of the most underused strategies. Methylphenidate and amphetamines work through different mechanisms. So if one class loses effectiveness, usually the methylphenidate, then you switch to the amphetamine. Another option is some people will add a non-stimulant adjunct. Adding guanfacine or atomoxetine can reduce the required amount of stimulant. So that's a good way to use less stimulant if that's the goal. And this is especially helpful for impulsivity and emotional reactivity and sleep disturbance. So combination therapy is often smarter than just dose escalation in this instance. The other thing is, think about using those extend release formulations. Peaks and troughs tend to drive tolerance, and extended release formulations can smooth out that dopamine signaling and reduce the rebound and improve adherence. So if a patient is cycling on and off all day long, likely they're going to achieve tolerance. And of course, lifestyle optimization. This seems to get underrated, but it's essential. This is, sleep deprivation. So make sure there's a good sleep schedule, and inactivity needs to be remedied. There should be good, consistent exercise and inadequate protein intake and inconsistent meals. All of that can mitigate the efficacy of this, right? The other thing is tyrosine availability, exercise, sleep hygiene. All of that influences the medication response. So the takeaway is simple here. Tolerance is a clinical signal. So you need to respond thoughtfully and make sure that lifestyle is coming along. So one of the key issues is these are so commonly prescribed, and I don't feel like enough emphasis is put on the safety and monitoring, because stimulant-related harm does not come from the medication itself, but typically from preventable and predictable errors. The first thing is with respect to screening. Cardiac screening. Sudden cardiac death with stimulants is rare, but think about it. It is catastrophic when it occurs. So this is a non-negotiable. So before starting any stimulant, you must screen for a personal or family history of syncope, unexplained sudden cardiac death, or known structural heart disease. This is not about ordering a routine EKG on everybody. This is about asking the right questions. If the history raises concern, exercise-induced syncope, palpitations, family member with sudden death under age 40, then the next step is clear, EKG and cardiac clearance. That's the American Heart Association Class 1 recommendation, okay? The next thing is timing errors. One of the most common mistakes as clinicians is in dosing stimulants too late in the day. If a stimulant is taken after 2 to 3 p.m., insomnia is predictable. So when families report sleep problems, the fix is rarely add melatonin. The fix is move it earlier in the day. Now, if a medication is wearing off too early, don't go pushing dosing later. Instead, consider a longer acting formulation or a short acting booster earlier in the afternoon. The other problem, of course, is the growth monitoring. So stimulants can suppress appetite, and over time that can affect weight, and occasionally it can affect height. This is a dose dependent, not an inevitable. So the standard therapy and treatment here is to plot height and weight every 3 to 6 months. If the growth is faltering, then reassess the dose, timing, nutrition, etc. Finally, comorbidity risk. So stimulant can unmask or worsen bipolar. So if a patient has a history of mania or hypomania, ADHD treatment has to come after mood stabilization. That's the last thing we're treating. Treat all the other things first, not before. This is a sequencing issue, so pay close attention. Now, growth and monitoring is essential because it's one of the areas that parents will have anxiety over, and clinicians, especially when they prescribe stimulants, are going to hear about this. So before starting any treatment, always establish a baseline. That means documenting height and weight and calculating the BMI and plotting everything on age and sex-specific growth charts. You're not just looking at the number, you're looking at trajectory. So ask about family growth patterns and timing of puberty so you're not misattributing some normal variation to medication. And once treatment starts, the growth should be monitored every 3 to 6 months at a minimum. And what matters most is the growth velocity. Is the child staying on their percentile curve over time? After dose increases, weight should be checked more frequently, often monthly, until things stabilize again. Now, red flags are dropping below 5th percentile or crossing 2 major percentile lines downward. That's when you intervene, not panic, just act. So you start with nutritional strategies like calorie-dense meals, bedtime snacks. If needed, you consider a dose reduction, medication holidays, or switching agents altogether. The key takeaway is growth suppression is usually modest and dose-dependent and manageable if you're monitoring it. All right, now we're going to shift gears into dementia pharmacotherapy. And this is an important conceptual pivot because up until now, much of psychopharmacology has been about symptom control. Dementia forces us to think a little differently. And here, the medications are not curative. At best, they're modest, disease-modifying at the margins. And every prescribing decision is going to carry some major trade-offs. So we're going to cover some 3 major domains here. First, the foundational agents. Those are the cholinesterase inhibitors, memantine, and what they actually do and what they don't do, and how to set realistic expectations with families. Second, we're going to address the anti-amyloid monoclonal antibodies, and then these are representing that shift towards disease modification, but they come with strict eligibility criteria and serious risks, and also complex REMS monitoring requirements. And then finally, we're going to focus on what you'll manage most often in practice, which are the behavioral and psychological symptoms of dementia. And this is where clinical judgment and risk mitigation and ethical constraint will be a factor. So this slide is the conceptual foundation for why cholinesterase inhibitors exist at all. So under normal conditions, acetylcholine is released into the synapse and binds to the cholinergic receptors in cortical and hippocampal circuits. This signaling supports the attention, learning, and memory, and the signal is normally terminated when acetylcholinesterase breaks down. Well, in Alzheimer's disease, the problem is not receptor failure first, it's progressive loss of the cholinergic neuron, particularly from the basal forebrain. Those neurons die, synaptic ACH levels fall, and cognitive efficiency declines. Cholinesterase inhibitors do not stop that neurodegradation process. They do something far more modest. All they do is inhibit the acetylcholine enzyme, slowing the breakdown of the limited ACH that's left and being released. So the result is this temporary increase in synaptic ACH, which can translate into small, short-term improvements in cognition or function. This symptomatic treatment, not disease fixing. And that's the distinction that you need to tell patients when counseling them and their family. Now this table compares 3 FDA-approved cholinesterase inhibitors and the key things regarding their efficacy. You'll note that it's fairly similar, and tolerability is the thing that drives which one to pick. So donepezil is the most commonly used first-line agent. It's a pure acetylcholinesterase inhibitor. It's dosed once a day with best adherence and broad familiarity. The trade-off, though, is GI upset, and meaning could be explosive diarrhea for some people. Also vivid dreams and bradycardia risk, so heart rate monitoring matters. The GI upset is not common, but it does happen, and you might need to warn people. Rivastigmine inhibits both acetylcholinesterase and butyrcholinesterase, and it's the biggest advantage is that it's a transdermal patch. So what happens? You're bypassing first pass effect. The GI tract is not interfered with. It's FDA approved also in Parkinson's disease dementia. The downside is this causes weight loss and anorexia, plus some skin irritation with the patch. The reason that matters is as dementia declines, appetite also declines. Galantamine adds a nicotinic receptor modulation, which may help with attention and apathy, but it has the highest GI burden and requires a renal dose adjustment. Importantly, all 3 have similar numbers needed to treat, meaning no agent is dramatically more effective. And these drugs offer modest temporary symptomatic benefit. These don't do disease modification. So selection is really going to be about dosing simplicity, comorbidities, tolerability of side effects, not potency. Now, this case here represents a very typical early Alzheimer's presentation. You got a 72-year-old woman with word-finding difficulties and short-term memory loss. Her mini-mental status gives you a 22, which puts her in that middle range. And at this stage, our goal is going to be symptom stabilization, not cure. So donepezil is a first line here, and we start at 5 milligrams nightly, titrate up to 10 after 4 to 6 weeks if tolerated. Once daily dosing improves adherence. That's why we like this one. And it has the strongest evidence base among the cholinesterase inhibitors because it was the first to market. Okay, so mechanistically, this works by inhibiting the acetylcholinesterase, increasing the availability, right, and in the remaining cholinergic neurons that have yet to die. This doesn't stop the degeneration, but it may slow a functional decline for about 6 to 12 months, sometimes longer. So keep that in mind as you think about deprescribing later on. How long have you been on this? So you need to explicitly tell the patient, this medication may help you stay where you are longer. It will not reverse memory loss. And the monitoring here is going to focus on the bradycardia and the GI side effects. So you check heart rate and blood pressure at every visit and consider an EKG if there's a cardiac history and reassess the cognition in 3 to 6 months using mini mental status exam or MoCA. And if it's tolerated, you continue. If it's not tolerated, you can switch agents. So this is about how to use a cholinesterase inhibitor, not just starting them, but how do you manage them safely over time. First is the titration. So these medications need to be advanced slowly, about every 4 to 6 weeks, to reach that therapeutic dose. Stopping at the starting dose is one of the most common clinical errors. If GI side effects occur, you don't abandon the drug. What you do is you pause. You hold the dose for another few weeks and then continue once tolerated. Secondly, vitals and safety. So these drugs increase acetylcholine, which means bradycardia is a real risk. Heart rate and blood pressure should be checked at every visit. And if the heart rate drops below 50, that's not watchful waiting, that's an EKG and possibly a cardiology consult. We're also watching for red flags, which include things like syncope, falls, weight loss, anorexia, and worsening agitation. And finally, cognition, because success here does not mean improvement. Success here is stabilization or slower decline. So you repeat the mini-mental, the MOCA, or the slums every 3 to 6 months. And we always ask caregivers about real-world function with respect to ADLs and IADLs. The function is holding steady. Now, given all those complications, that is the case that some people will not start patients on these medications because the bang for the buck to some is not worth it. The risk of syncope and falls and polypharmacy and weight loss and anorexia may not be worth the plateau that we're trying to create. But that's a counseling and discussion decision. So this case highlights a very common real-world problem with the cholinesterase inhibitors, which is the GI intolerance. Here we have a 68-year-old man with moderate Alzheimer's disease who developed significant nausea and diarrhea shortly after starting the donepezil. And this is the classic dose-limiting GI side effect that forces people to have this conversation about is this medication worth it? So the key move here is not necessarily to abandon the medication because they may really want something, but switch the route of delivery. So if the oral donepezil is causing this, then rivastigmine transdermal patch is ideal in this scenario because you bypass the GI tract and first pass metabolism, and it reduces nausea, vomiting while providing that 24-hour cholinergic stimulation. And that steady delivery also avoids peak-related side effects with the oral dosing. So you'd start the patch at 4.6 milligrams for 24 hours for the first 4 weeks, and if it's tolerated, you can go up to 9.5, which is the minimum effective dose. For moderate to severe disease, you can go up to 13.3 milligrams if needed, and it matters. So you want to apply this to a clean, dry patch of skin on the chest or upper back or arm and rotate the sites daily. And always remove the old patch before applying the new patch so we don't have overdose. So if the GI intolerance is limiting this class of medication, know that the patch is available. All right, let's talk about memantine because this works on a completely different neurotransmitter system than the cholinesterase inhibitors that we just covered. So instead of acetylcholine, this drug is targeting the glutamatergic system and specifically the NMDA receptor. Memantine is an uncompetitive NMDA receptor antagonist, and it binds inside the channel pore at the magnesium site and does so in this voltage-dependent way. That means it preferentially blocks the channel only when it's excessively open, which is what happens in things like Alzheimer's pathology. In Alzheimer's disease, there's a chronic low-level glutamate activation, so think of it like as a constant background noise. This leads to calcium overload and excitotoxicity and progressive neuronal injury. Memantine dampens that pathological signaling and protects neurons from ongoing damage. Memantine does not shut down normal learning. It has a rapid on-off kinetic. So when a strong physiologic glutamate signal comes through, like during attention or memory formation, the drug disengages and allows normal transmission. So why memantine is better tolerated than older NMDA antagonists and why it's used in moderate to severe Alzheimer's, often in combination with the cholinesterase inhibitors because of that rapid on-off kinetic function. So memantine reduces excitotoxic damage while preserving useful cognitive signaling so that it's seen as neuroprotection, not stimulation. So who should get memantine? Well, those with moderate to severe Alzheimer's, that's who it's indicated for. And in practice, you're usually waiting for that mini mental status score to drop below 20 or when there's a clear functional decline despite cholinesterase inhibitor therapy. And dosing matters because dizziness is the most common early side effect. That's why memantine is titrated weekly. That's why there's a high risk of falls on this medication. So with immediate release, you start with 5 milligrams once daily, and then you titrate to a target of 10 milligrams twice daily. There is an extended release formulation of 7 milligrams once daily, and that's titrated to 28 milligrams once daily, which tends to improve adherence because it's a once-a-day pill. From an evidence-based perspective, the number needed to treat is 8 to 10 for stabilization or modest improvement. That means 8 to 10 people need to take it before someone benefits. The number needed to harm is around 20, which tells you it's generally well tolerated. But the most common side effect, like I said, is dizziness and headache and mild confusion. They're usually transient, but we need to watch for falls in that transient period. So we don't use memantine in isolation if the patient can tolerate the combo therapy. There was a Domino AD study that showed that adding memantine to donepezil in moderate to severe Alzheimer's leads to better cognitive and functional outcomes than cholinesterase inhibitor monotherapy alone. So memantine is low-risk additive therapy that modestly slows decline and helps preserve function in later stage disease. But remember, everything is trade-offs. Now, this case illustrates when and why we escalate combination therapy in Alzheimer's. So if a 75-year-old patient who has been stable on donepezil 10 milligrams daily for about 18 months and now shows a clear progression, her mini-mental status dropped from 20 to 16, and the caregiver is reporting increased confusion and dependence in activities of daily living. So this is a classic inflection point. The cholinesterase inhibitor isn't failing, it's doing what it can, but the disease has advanced enough that cholinergic support alone is no longer sufficient. So the next step here we're saying is to add memantine, not replace the donepezil. So you start at 5 milligrams once a day, titrate that up to 4 weeks at 10 milligrams twice a day, and while continuing the donepezil. So mechanistically you're targeting those two distinct pathways of glutamate modulation. So the bottom line is, when moderate Alzheimer's progresses despite optimized cholinesterase inhibition, combo therapy is evidence-based and rational and clinically appropriate, but, requires a conversation. So this is the paradigm shift. So this slide is about Alzheimer's treatment, but disease modifying now. So this is anti-amyloid antibodies, right? These are disease-modifying monoclonal antibodies designed to target amyloid beta plaques and protofibrils, not symptoms. So the goal is going to be clearing pathologic aggregates from the brain. Now, importantly, these agents are not for everybody. The target population is mild cognitive impairment, so early disease, or mild Alzheimer's dementia only. And patients have to have confirmed amyloid pathologies, so typically via PET scan or CSF biomarker. And moderate or severe dementia is outside the indication because this requires a high degree of compliance. If they're moderate to severe dementia, the compliance and the logistics are going to be quite difficult here. Now, what makes these drugs different is that they are first pharmacologic therapies shown to slow disease progression on the order of about 27 to 35%, rather than simply providing this temporary symptomatic benefit like the cholinesterase inhibitors and the memantine. That said, this benefit comes with significant complexity. So this requires MRI monitoring because of these ARIA, which is amyloid-related imaging abnormalities, which, like I said earlier, includes brain edema and microhemorrhages. So because of this, prescribing is not just about writing an order. This involves careful patient selection, shared decision-making, and imaging infrastructure for where they can go consistently and have this done, as well as ongoing safety surveillance. So bottom line is anti-amyloid antibodies represent a major shift in the scientific thinking, but it is a very high burden, high risk, and appropriate only for a very narrow, carefully screened population of mild Alzheimer's. Lecanemab Leqembi. So this is currently the flagship anti-amyloid antibody and the clearest example of what disease-modifying Alzheimer's treatments look like in real practice. It received accelerated FDA approval in January of 2023, followed by traditional approval in July of 23. So based on confirmatory clinical outcomes. So mechanistically, lecanemab is a humanized monoclonal antibody that targets soluble amyloid beta protofibrils, which are upstream from plaque formation. So this is important because it intervenes earlier in the amyloid cascade rather than just clearing deposited plaques. The indication is strictly limited to patients with mild cognitive impairment or mild Alzheimer's dementia who have confirmed amyloid pathology by PET or imaging. This is not appropriate for moderate to severe Alzheimer's dementia. So in terms of efficacy, it's demonstrated to be about 27% slowing cognitive functional decline. Clinically, that number needed to treat is about 12 to 15, meaning only a subset of patients experience meaningfully slow improvement. And the trade-off is that number needed to harm, which is 20 to 30, and it mandates serial MRI monitoring. Now here's the drug alone costs $26,500 per year, not including infusion services and MRI imaging. That makes this a very high resource, high burden intervention. The bottom line is this only offers modest but real disease slowing for a carefully selected patient, and it requires a lot of monitoring and infrastructure. Now, donanemab represents a distinct evolution in this therapy. So this thing received approval in 2024. This targets insoluble amyloid plaques, specifically N3pG modified form, meaning it's directed at plaques that have been established. So the other one was pre-plaque. This one is at plaque that has been established. The dosing regimen is also different. So treatment with this begins at 700 milligrams IV every 4 weeks for 3 doses, and then it escalates to 1400 milligrams IV every 4 weeks. Importantly, this is not an indefinite therapy. So this defining feature of Kisunla is that it is finite in duration. And treatment is stopped once the amyloid plaques are sufficiently cleared on imaging around 12 to 18 months. So this potentially reduces long-term cost and infusion burden and cumulative exposure. In terms of efficacy, this showed about 35% slowing of clinical decline, but only in patients with low to intermediate tau burden, and this makes tau stratification essential before initiation. The trade-off is this has a higher ARIA risk than lecanemab, so 24% ARIA with this. So strict MRI surveillance is essential. The bottom line is this offers greater slowing and finite treatment, but at a cost of a higher ARIA, so it's a more risky drug. So if we compare these two side by side, you'll see here Leqembi compared to Kisunla. They're not interchangeable. They represent two distinct strategies, right? Leqembi targets the soluble amyloid beta protofibrils, and it's given every 2 weeks, and it's designed as a continuous chronic therapy. And by contrast, Kisunla is targeting the insoluble amyloid plaques, and its dosing is front-loaded and finite, and mono infusions with treatment stopping once the plaques are cleared. So in terms of efficacy, Leqembi shows about 27% and Kisunla 35%, but only in the patients with a low to intermediate tau burden, and safety is where the trade-off happens. The ARIA risk is lower with the Leqembi compared to the other, and the cost profiles are comparably high, but one is indefinite and the other is short-term. You're looking at $26,500 compared to $32,000 for a limited duration. Leqembi is steadier, lower risk chronic therapy. Kisunla is more aggressive finite therapy with higher monitoring demands. So something to consider. So what is ARIA? This is the central safety issue with those medications, both of them. Anti-amyloid monoclonal antibodies. So there are two forms. There's ARIA-E, which refers to vasogenic edema or sulcal effusion. And this is essentially the brain swells related to vascular leakiness as amyloid is cleared from the vessel wall. And then there's ARIA-H, which refers to the microhemorrhages or the superficial siderosis, reflecting small vessel fragility and iron deposition. So importantly, these findings are mechanistically linked to plaque removal, not an off-target toxicity thing. So we are destabilizing amyloid-laden vessels as part of the treatment. Now, that APOE4 status dramatically stratifies risk. So patients have ARIA rates as high as 30 to 40% compared to 12 to 15%. So that's why genetic testing is clinically actionable in this case. And the clinical thing to keep in mind is most ARIA, roughly 75 to 80%, is asymptomatic and the patient feels fine. You only detect it if you follow the MRI surveillance protocol. I suspect that protocol will be going away soon. And that makes MRI monitoring non-negotiable in this situation for now. And if they miss scheduled imaging, it's considered a patient safety failure, not a minor lapse. So ARIA is common, it's silent, it's predictable and manageable, but you have to look for it. All right, so this slide is now where we're going to focus on the behavioral and psychological symptoms of dementia. Namely, we're dealing with agitation, aggression, psychosis, and paranoia. These are what make dementia patients very challenging, and dementia care especially. But they're also where we can cause the most harm if you are careless. So first of all, any discussion of antipsychotics has to start with the FDA black box warning. So in older adults with dementia-related psychosis, antipsychotics are associated with 1.6 to 1.7-fold increase in mortality, primarily from cardiovascular events and infections like pneumonia. So because of that, antipsychotics are never first-line treatment for behavioral and psychological symptoms of dementia. So it's a very narrow indication. So severe agitation or psychosis causing imminent danger or extreme distress after non-pharmacologic interventions have failed. When medications are unavoidable, we have to choose very deliberately. So quetiapine is often selected when sedation is needed, has the least EPS, can still happen. The next one often is aripiprazole if you want less sedation and lower metabolic burden. The problem is that half-life is very long in aripiprazole and they're already metabolizing slowly. Sometimes people may use olanzapine because it can be used to consolidate sleep at night and stimulate appetite, which is often one of the biggest issues, is the agitation persisting through the night, making it difficult to sleep, causing downstream insomnia effects. Whatever drug you're choosing, you must start low and go slow and reassess frequently. And it should be a time-limited trial with clear documentation and informed consent to that black box warning and ongoing risk-benefit. Sometimes this is required for the patient to even allow care. So that's another consideration. There are often safer first-line options to consider. SSRIs, such as citalopram, sertraline, are commonly used for agitation, depression, or anxiety. If sleep is the primary driver, trazodone is frequently helpful. Also, breaking the dose into smaller increments and using it during the day can be something to consider. Just know, antipsychotics in dementia are risk acceptance decisions. They are not routine care. The ethical dementia treatment means we intervene only when the risk of not treating it exceeds the risk of medication. And then we have to continually ask whether the drug remains necessary. I mean, sometimes it's necessary because they're so disruptive they cannot stay in their current care environment, like the lovely assisted living that they happen to be in. And if they get kicked out, where are they going to go? They don't qualify for a nursing home just yet, and they're not hospitalizable, and they're punching the home health aide. That's a risk-benefit conversation that needs to be had. Now, no psychopharm lecture on cognition would be complete without talking about some of the medications that can worsen cognition. So, how much cognitive harm are we causing unintentionally through medication? So, by the time the patient reaches us with dementia or cognitive impairment, the disease is really only part of the story. The medication list itself will often explain a significant portion of confusion and falls and sedation and functional decline. So in this section, we're going to focus on the 4 major contributors to cognitive decline. The first is going to be anticholinergic burden, one of the most common and preventable causes of medication-induced cognitive decline. Second, benzodiazepines and Z drugs, which impair memory, attention, balance, and sleep architecture, and dramatically increase fall and delirium risk in older adults. The third are the antipsychotics and anticonvulsants, which may be necessary in limited situations, but often worsen cognition, sedation, and mortality when used chronically without clear indication. And then, of course, we have to talk about deprescribing, not as an afterthought, but as a core clinical skill, because good dementia care isn't just about what we add, it's about knowing what to stop, when to stop, and how to stop safely. So the primary goal here is very practical. You want to identify those high-risk medications, understand why they worsen cognition, and apply a structured deprescribing strategy that improves clarity and safety and quality of life. And in many cases, the most effective cognitive intervention we have is removing the drug that should have never been there in the first place. Now, this slide introduces one of the most practical tools we have in identifying medication-induced cognitive harm. This is called the anticholinergic cognitive burden scale. The ACB scale assigns points to medications based on their anticholinergic activity. So a score of 1 reflects mild anticholinergic activity, drugs that may show serum anticholinergic effects but usually aren't the sole cause of impairment. A score of 2 indicates moderate anticholinergic burden with clinically meaningful cognitive effects, especially when combined with other agents. And a score of 3 represents strong anticholinergic medications, drugs that clearly associated with delirium, and they accelerate cognitive decline and increase dementia risks. What matters clinically is the cumulative score, not just one medication. So a total ACB score of 3 or higher is a red flag. It's associated with more rapid cognitive decline, higher dementia risk, increased falls, and higher mortality in older adults. The clinical goal is straightforward. You want to systematically review the medication list and drive the total ACB score below 3 whenever possible. This doesn't mean stopping everything overnight. It means identifying the high burden drugs and prioritizing substitutions and recognizing that for many patients, cognition improves not when we add something new, but when you remove the offending agents. So this slide highlights some of the most common and most dangerous contributors to anticholinergic cognitive burden in older adults. The first generation antihistamines are a major culprit. That's diphenhydramine, Benadryl. It's everywhere. It's an allergy med, sleep aids, Tylenol PM, Z-Quil. These drugs carry an ACB score of 3, meaning strong anticholinergic effects, and are directly associated with delirium, confusion, falls, and accelerated cognitive decline. Hydroxyzine falls into the same category despite being prescribed for anxiety and itching. It's not benign in older adults. Also has a score of 3. Tricyclic antidepressants are another high-risk group. Amitriptyline, nortriptyline, often prescribed for sleep, pain, headaches. Both carry a high score. Even at low doses, they significantly worsen cognition and increase delirium risk in patients with mild cognitive impairment or dementia. So the key thing here is substitution, not abandonment of treatment. So for allergies, we prefer second-generation antihistamines, cetirizine, loratadine, fexofenadine, which is the least deliriogenic. And for sleep, we like melatonin, low-dose trazodone, safer options. For anxiety, buspirone and SSRIs are preferred. For neuropathic pain or depression, we want to consider SNRIs, gabapentin, pregabalin, duloxetine, instead of TCAs. If a patient has cognitive impairment and is taking diphenhydramine, hydroxyzine, or a TCA, that medication should trigger an immediate review. These drugs are modifiable risk factors for cognitive decline, and deprescribing them is one of the highest yield interventions. Now here I want you to see how anticholinergic burden shows up outside the obvious places. So first, typical antipsychotics like chlorpromazine can carry an ACB score of 3. That's not subtle. These agents block the M1 receptor and can directly worsen cognition, especially in older adults. So if an antipsychotic is truly necessary you want to favor atypicals with lower anticholinergic activity like aripiprazole or quetiapine. Next, bladder antispasmodics. Oxybutynin and tolendrine are classic offenders. These are extremely common, often prescribed by other clinicians and frequently missed. Mirbegaron avoids cholinergic blockade entirely, so that's a nice option. Trospium is another option because it does not cross the blood-brain barrier. Cyclobenzaprine looks benign but behaves like a tricyclic in terms of sedation, confusion, and falls. Some non-pharmacologic approaches should be tried first line. Finally, promethazine. This is a strong anticholinergic drug activity, and there are many safer alternatives for nausea like ondansetron when available. That's the pattern of substitution, not discontinuation. Now this slide is your clinical playbook. So step 1, you want to review the entire medication list at every visit. And that includes over-the-counters and sleep aids and cold medication, and diphenhydramine is everywhere. The next thing you want to do is calculate that cumulative anticholinergic burden. So tools like MD-Calc or ACB-Calc make this fast and easy to do. So a total score of 3 or higher, clinically meaningful. Third thing you want to do is substitute systematically. Don't just stop, replace. So mirabegron instead of oxybutynin, trazodone instead of diphenhydramine. And then step 4, you want to track outcomes. So you want to follow cognition and activities of daily living after the medication changes. So this turns your deprescribing into a measurable intervention, not just a theoretical good idea. Benzodiazepines deserve their own warning label when it comes to cognition. So acutely, they cause anterograde amnesia. That is, impaired learning and attention deficits. So often, immediately after dosing, it's going to be hard to take in and hold on to new information. And patients may feel calmer while becoming less cognitively functional. So chronically, the data is concerning because meta-analyses have shown that 1.5 to 2-fold increase in risk of dementia with long-term use beyond 3 to 6 months. And in older adults, those risks multiply for falls, hip fractures, delirium, and paradoxical agitation. So these are not rare edge cases. They are predictable pharmacological outcomes. The takeaway is simple. Benzodiazepines trade short-term symptom relief for long-term functional and cognitive harm, especially in the aging brain. Now this slide answers the most common pushback questions. Like, if we're not using benzodiazepines, then what can we possibly do? Well, for anxiety, benzodiazepines are have specific agents to avoid, right? So we want to avoid alprazolam, clonazepam, lorazepam. Instead, ideally, you want to treat that underlying disorder. So you'll do things like SSRIs, SNRIs, buspirone, things like addressing the anxiety without impairing cognition or creating dependence. Well, what about for insomnia? Well, you want to avoid benzodiazepines and Z-drugs, so no temazepam, zolpidem, aspicolone, none of those, because all of those impair cognition. Ideally, cognitive behavioral therapy for insomnia is first line, meaning track the symptoms and all of the tricks and skills you learned last semester. If a medication is indeed needed, then you want to go low-dose trazodone or melatonin, much safer options. And for agitation in dementia, lorazepam PRN is a common but harmful reflex. It worsens confusions and falls. So you want to start with environmental modifications. If you need maintenance, SSRI like citalopram, sertraline for sleep and calming. Trazodone is good for that. So the theme is treating drivers, not sedating symptoms. So this slide is an outline of how to taper the benzo, because we can't just rip this off without risk and harm. So the first taper schedule here, you want to reduce the dose by about 10 to 25% every 1 to 2 weeks and never stop them abruptly, because the seizure risk is real. Go slower if needed, but head in the right direction, especially in older adults. This could take months. If withdrawal symptoms emerge, hold the dose until they're stable before continuing. Second, the conversion strategy. So for short-acting agents like alprazolam, you want to consider switching to longer-acting agents like diazepam. The longer the half-life, the smoother the peaks and troughs will be, and you will reduce those interdose withdrawal symptoms. And you always want to calculate equivalency carefully using a standard conversion table. Third, you want to look at bridging therapy. So you want to start the alternatives early, like SSRI or buspirone for anxiety. For rebound insomnia or agitation, low-dose trazodone can help. And don't skip the non-pharmacological CBT for insomnia and sleep hygiene as essential for long-term success. Now this slide helps you rank antipsychotics by cognitive cost, not just symptom control. So start with a typical antipsychotic like haloperidol or chlorpromazine. Now these have severe cognitive impact due to strong D2 antagonism. So you should expect slowing of processing speed and impaired attention and executive dysfunction. In patients with cognitive disorders, these should generally be avoided. Clozapine is also in the severe category. So while it has unique efficacy, its strong anticholinergic burden leads to global cognitive impairment and sedation. This is why clozapine should be avoided in dementia. Quetiapine falls into a moderate range group. Its cognitive effects are largely sedation related through H1 and alpha-1 blockade. So use the lowest effective dose. It can be useful for agitation or sleep, but the dose creep matters here. Other atypicals like risperidone, olanzapine are variable. Their cognitive impact is dose dependent, so use time-limited trials and monitor closely for metabolic and EPS side effects. And finally, aripiprazole has the mildest cognitive profile, but one of the longest half-lives. It's a partial D2 agonist, and it produces the least cognitive impairment. So often when paired with long-term antipsychotic use is necessary, use is unavoidable, this might be the game plan. But it's all trade-offs. Now, this slide compares mood stabilizers by how much they cost cognitively, not just how well they stabilize the mood. So start, first of all, with topiramate. This is the most offensive agent for cognition. It has the nickname Dopamax because it can trigger word-finding difficulties and slowed processing speed and memory impairment. So if cognition is a priority, avoid this drug. And in patients reporting brain fog, switch from this drug. Valproate falls into the moderate category, and it commonly impairs attention and processing speed, and the effect is a dose-dependent effect. So use this with caution and monitor the cognition over time. If impairment emerges, then dose reduction should be considered. Carbamazepine is also moderate with memory and attention deficits, plus an added layer of complexity because of the CYP3A4 induction. So drug-drug interactions can worsen both the cognitive and systemic toxicity. Lamotrigine stands out as the most cognitively sparing option. It has minimal cognitive impact and is often preferred for bipolar patients with cognitive concerns or mild cognitive impairment. And finally, lithium. And therapeutic levels, the cognitive impact is minimal with lithium. So the risk comes from toxicity and delirium and confusion. So in older adults, those with renal impairment, you need to monitor the level carefully. We're wrapping up shortly, so now I want to review and highlight these 5 preventable errors that consistently worsen cognitive outcomes. The first is the anticholinergic burden. Prescribing medications with an ACB score of 3 or higher in cognitively impaired patients is a common mistake, and the correction is to simply calculate the score and deprescribe when it's 3 or above, switch to non-anticholinergics. The others is second is the cholinesterase inhibitor underdosing. So you want to start donepezil at 5 or rivastigmine, and then remember to titrate up. Unless the side effects are limiting, you need to titrate to the target after 4 to 6 weeks. Third is the no cardiac screening. So starting stimulants without assessing cardiac history risks serious events. So always screen for syncope and family history of sudden death, and order the EKG when high-risk features are present, and consider cardiology consultation. Fourth, the MRI non-compliance with anti-amyloid therapy, missing required safety MRIs risks for undetected ARIA, and these imaging schedules are non-negotiable for safety and drug coverage. Fifth, the additive effects of polypharmacy are to be considered. So adding a cognitive enhancer without first removing a harmful medication is undermining the benefit. So the rule is to deprescribe before you prescribe. And avoiding these 5 errors will prevent real harm and can cause meaningful cognitive improvements in patients. Now, this final slide distills the entire lecture into some practical take-home points. So for ADHD, the management is you start with methylphenidate, extend release. For tolerability, you may switch to an amphetamine class only if the response is inadequate. Remember, cardiac history is mandatory before starting, with EKG if risk factors are present, and monitor height and weight every 3 to 6 months. Growth suppression is dose dependent. For Alzheimer's dementia, start the cholinesterase inhibitor early in mild to moderate disease. Add the memantine as the disease progresses. Combination therapy outperforms monotherapy. And then refer motivated patients with mild cognitive impairment and mild Alzheimer's. They could be considered for the disease-modifying therapies. But be mindful of ARIAs. Now, for the behavioral and psychological symptoms of dementia, non-pharmacologic strategy should always come first, with antipsychotics as the last resort due to the risk of mortality, that is death. And medications to avoid are consistent themes of anticholinergic, check the score of the anticholinergic score 3 or higher. You want to get that down. Benzodiazepines in cognitive impairment due to increased dementia risk, and the typical antipsychotics because of severe cognitive dulling. So avoid those and deprescribe and substitute. Finally, decision making should always be framed by the number needed to treat and the number needed to harm. Stimulants have very strong efficacy. Cholinesterase inhibitors offer modest benefit. The lecanemab requires careful risk-benefit discussion. So the unifying principle is be deliberate and consider cognition preservation when you are prescribing. Thank you for your attention.